This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
Hi everyone, and welcome to this recording for the Suicide Care Research Center Methods Course Asynchronous seminar series. My name is Lucas O'Brien. I'm a human-centered design research scientist for SCRC, and today I'm going to be presenting an overview of the Discover, Design, Build, and Test framework. So I want to cover some learning objectives before I dive into anything today. After watching this presentation, you should be able to summarize the 3 phases of the DDBT Framework for human-centered design and the respective outcomes for each phase. You should also be able to align your research plan and the methods in that research plan with the DDBT approach using or after you go through SCRC's project intake process. And then finally, you should be able to recognize DDBT's connection to the preparation phase of the MOST framework. So this presentation has 3 parts. I will start off by digging into what do we mean when we say the word design. Second part, I'll cover specific outcomes in the DDBT framework. And then finally, I'll touch on co-design and other values considerations when we go about a design process. So to begin, what do we mean when we use this word design? It's really important that we clarify what our design framework is and what that means and what implications it has. So if you've done design work before, or if you're newer to the field, there's a plethora of terminology out there: human-centered design, design thinking, user-centered design. You might hear interaction design, service design, a plethora of terms. And with that comes a plethora of design frameworks that you're going to come across. On this page here, I have 4 examples of design frameworks. Many of these frameworks have shared principles and are often very similar. So in the top left is the double diamond. This is one of the most widely known and widely disseminated design frameworks. Top right here is the human-centered design taxonomy that I utilized when I was at a previous design center. We have the ISO standard for human-centered design, and then the DDBT framework. And the value of having a human-centered design framework is to guide thinking, to choose what works, and to adapt when necessary. There are underlying similarities to many of these human-centered design frameworks. You'll see that in a few slides when I discuss what the principles of human-centered design are. At SCRC, we're utilizing the DDBT framework, Discover, Design, Build, and Test framework. This was developed by our friends over at UW's Alacrity Center, UW-AC, and they've put together a really great video providing a brief overview of the framework. So I'll present this video, and then we'll cover some key differences and nuanced specifics for suicide care and our center.
User-centered design is an iterative, problem-solving method in which you focus on truly understanding the users, their perspectives, and their needs in each phase of the design process. In looking to design or redesign mental health treatments, or the ways they are implemented, there tends to be multiple users to consider. At a minimum, there is the patient and there is the provider delivering the intervention. You must be prepared to try things quickly, get lots of feedback, and not be too invested in any one solution too early in the process. UW Alacrity Center's DDBT framework, which stands for Discover, design, build, and test has been developed based on best practices from the fields of user-centered design, implementation science, participatory action research, and service design. All of the pilots our center supports are asked to use this methodology. In the upfront discover phase, we identify the different needs and points of views of all the stakeholders. These needs can be both stated and unspoken. This is when you try to really understand the unadapted evidence-based psychosocial intervention and its context. What is the physical setting and social environment the EBPI currently is, as well as will be delivered in? This includes sociocultural factors such as income, education, and cultural norms of all the end users, the organizational structures, as well as any artifacts, both tangible and digital materials that are used. Most importantly, this is when you really need to clarify what the problems are that need to be addressed. What are the usability issues and any other barriers there are to implementation? In the design phase, you synthesize your findings and insights collected during the discover phase. This is your opportunity to test assumptions that you or the stakeholders may have about either the problems themselves or the potential solutions. You define requirements for possible solutions and come to a consensus on how you will define success. At this point, you start ideating concepts, developing a large number of possible divergent ideas that could evolve into solutions. I mentioned earlier that part of using a user-centered design process involves not being afraid to fail. That is where the testing and iteration comes into play. When people decide too early in the process what they think the solution is, they invest time, money, and emotion into that solution and are more likely to ignore feedback that it might not be the right path. By creating quick, low-fidelity prototypes that are constantly being brought back to the users for feedback, modifications, and validation, we are more likely to land on an innovative solution that meets the needs of the users long-term. While the DDBT framework is outlined with one phase seemingly leading to the next, in practice the process is carried out in a more flexible and nonlinear fashion. More than one phase may occur concurrently, and results from the build phase may reveal some insights about users, which in turn may lead to another brainstorming session to ideate and develop new prototypes. Finally, you get to the test phase, and at this point you have reached enough consensus that you feel comfortable finalizing a solution. You develop a high-fidelity prototype and implement a pilot to evaluate the feasibility of the solution in a real-world context.
So Alacrity's recording there provided a great overview of the DDBT process, and I just wanted to highlight some of those principles of human-centered design that are captured within that specific framework. So the active involvement of users and a clear understanding of user and task requirements, the appropriate allocation of function between user and system, the iterative process of developing design solutions, which you see in design build being treated almost as one phase, and then the multidisciplinary design teams, which you'll see reflected in the composition of folks that we have involved at SCRC. I also wanted to highlight some differences between SCRC's current iteration and the UW Alacrity Center, UW-AC, at the time of the recording that video was recorded. So SCRC, we are singularly focused on suicide care in outpatient medical settings for adolescents and young adults 13 to 30 years old. UW Alacrity Center was much broader in which interventions and which areas they were focused on. They weren't as narrowed in scope. Also different that SCRC teams might be working on a project where a pre-existing intervention, service, or practice does not yet exist. So your discover phase may be investigating current practice. At UW Alacrity Center at the time of the recording of that video, all of their projects were coming in and beginning with an existing evidence-based psychosocial intervention, an EBPI. And so their discover phases were about the current existing status of that intervention. So that's a slight difference there. And then lastly, suicide care is highly stigmatized, and that stigmatization makes suicide care particularly challenging for clinicians, patients, and family members alike. And as research teams, you'll need to approach this topic with sensitivity and awareness for how that stigmatization and the complexities of suicide care affect all parties involved. Another noteworthy difference, and something that's really important, is that DDBT is a smaller part of SCRC's broader methodological framework. So DDBT actually serves as accomplishing the goals of the preparation phase of another framework called MOST, the Multiphase Optimization Strategy. And from the outputs of the DDBT process, you can move into an optimization phase for MOST and then an evaluation phase. So I'm really excited about the potential that this methodological framework has. There's going to be another asynchronous seminar series that presents on the multi-phase optimization strategy, so be sure to check that one out. All right, so now that we have a little bit more understanding of what we mean when we say design, I want to transfer into talking about the DDBT specific measures and outcomes and what your expectations are for each phase within this framework. At SCRC, we have a number of common data elements, and these are an agreed upon set of measures that will be utilized across projects. For the DDBT phase, I've highlighted our common data elements here. Both are required and optional ones, and I want to walk through these with you. So acceptability is the perception among interested parties that a given intervention, service, or practice is agreeable, palatable, or satisfactory. So it's really personal in its criteria. Appropriateness, on the other hand, is the perceived fit, relevance, or compatibility of the intervention, service, or practice that you're designing for a given outpatient medical setting, provider, or patient. You can also think of this as the perceived fit of the intervention, service, or practice to addressing a particular issue or problem in suicide care. And the criteria for appropriateness ends up being a little bit more technical or social. And then feasibility is the extent with which a new intervention, service, or practice can be successfully used or carried out within a given outpatient medical setting. And that criteria is really practical. So the AIM, IAM, and FIM are the respective instruments that will measure acceptability, appropriateness, and feasibility. These are all 4-statement probes that a respondent ranks on a 5-point Likert scale, and the AIM and FIM are going to be required. IAM is optional. As we look at usability, usability is the degree to which an intervention, service, or practice can be used easily, efficiently, and with satisfaction or low user burden by a particular end user. And the system usability scale is a 10-statement probe, also with a 5-point Likert scale. So those are your required measures. You have the user burden scale as optional as well. The required measures, the AIM, FIM, and SUS, should be collected at each phase of DDBT. And then also with usability, we're going to have this qualitative usability reporting process, and you'll cover that when you meet with the methods core as you transition between phases. A template of all of these instruments, as well as the other common data elements, is going to be made available to your team. If you have questions regarding these common data elements, please contact Amanda, who is our data manager. So as we transition from those common data elements, let's look at each phase and the specific outcomes for those phases. In the discover phase, remember, this is all about defining your user needs and understanding the context of use. So your outcomes for this phase are going to be, first, that user needs are succinctly articulated and backed by sufficient evidence. And we'll know that it's backed by sufficient evidence when you meet with the methods core. We'll help you evaluate that. And then your second outcome is that the context of use for the intervention, service, or practice is specified, including the barriers, constraints, and facilitators. And so an example here is that the STRIVE project is interested specifically in suicide care in integrated behavioral health settings, particularly collaborative care. So we want to make sure, as we're finishing the discover phase for the STRIVE project, we're really understanding the context of use that is specific to integrated behavioral health settings. I just want to remind you all that this is our most open-ended phase, and at this point, you really want to avoid solution jumping. It's about understanding this context of use and having that well-defined before we ever move into defining what a solution could look like or what an intervention, service, or practice will look like. That is, if you're starting discover phase open-ended, you may already be starting with an existing intervention, service, or practice, in which case it would be slightly different. The common data elements, again, you want the AIM, FIM, and SUS to be collected here. If that intervention does not yet exist, these instruments will be adapted so that they're assessing current practice. And then your team will report those usability issues when you meet with the methods core at the conclusion of this phase. Then we move into design build. And these are, you can think of them as two phases. They're treated as one phase in the DDBT framework. I'm going to talk about them a little bit as two phases here. So in the design phase, the outcomes for design are that the user needs and context of use are mapped to specific requirements for functional components of whatever intervention, service, or practice you end up designing. And so that's really mapping out, we heard this, and so our intervention, service, or practice needs to be able to do this, and making those connections very explicit and clear. And then the build phase, the outcomes for the build phase are multiple concepts incorporating those design requirements are ideated, and then those are prioritized based on the acceptability, feasibility, and usability for potential prototyping. And you're going to go through an iterative prototyping cycle, which is what the second outcome highlights here, that prototypes will be created for iterative feedback from involved parties on acceptability, feasibility, and usability. So think of these as almost loops between design and build here. And then as you get more and more refined on your prototype, your finalized prototype will be selected for testing in real-world settings based on user feedback. So you want your final outcome of the design build phase to be this finalized prototype or prototypes of concepts or of intervention, services, or practices that you can bring into a pilot test in the real world. The common data elements, again, you want to collect the AIM, FIM, and SUS. You should be able to demonstrate an SUS score of greater than 70 as you're concluding the design build phase. And you obviously want to be improving your AIM and FIM scores from the discover phase. We want to see that improving. Your team's going to report any new usability issues you've identified. And at some point, as you're wrapping up design build, you're going to initiate a REDCap build process with SCRC's data manager. And that REDCap build is going to allow you to assess really robustly this test phase and the pilot testing of the final prototype in vivo. In test phase, your outcomes are going to be the acceptability, feasibility, and usability of the final prototype have been evaluated in a real-world setting, and that the intervention, service, or practice being designed is ready for implementation either into future research, so continuing on through the MOST framework, doing a randomized control trial, something like that, or it's ready for implementation into an existing practice. Common data elements, again, we want to see AIM, FIM, and SUS collected for this real-world pilot, and your team will again report any of those usability issues you identified in the test phase. So that was a summary of the different phases and the outcomes at each phase. I really want to hit on here in our next section, just make a quick note on co-design and this terminology and how we think about values in our design practice and the design approach at SCRC. Co-design, it's not a term that's well defined in the literature and in the design community more broadly. At SCRC, we're seeing co-design as reflecting principles that guide our processes. I want to note that it is not in and of itself a specific method, but rather provide some guidance and framing around ways we would go about those methods. And I'm deeply inspired by K.A. McKercher, who's a designer. They wrote a fantastic book called Beyond Sticky Notes. And I want to highlight just 4 of the co-design principles they name, because I think they're a useful starting off point. So they name sharing power between parties who are contributing to the co-design work, prioritizing relationships between all parties who are involved, using participatory means, and then really focusing on building capacity. These co-design principles and our co-design principles are in flux. They're reflected across our projects to varying degrees right now, and we'll help you and we'll work with you to determine what that will mean for your project, your team composition, and the methods that you select. I would say we're still actively determining what these co-design principles for our center are going to be. So we invite this as an open conversation and an invitation for you to contribute to what these will end up being in their next evolution and iteration. And then I'll also name that there is currently a narrative review of co-approaches, co-design, co-production, co-creation, a little bit of community-based participatory research in there, reviewing what is existing literature for suicide care for adolescents and young adults. So that is currently in progress. We share this, and I share this note here because you want to be really careful when publishing, when using the word co-design. You want to define what you mean because it's not well defined. And then I also think that there's an important note here about values and principles that are getting baked in. And when we're not explicit about what principles or values we're baking in, we really risk producing the values of dominant culture, and in many cases, this can cause harm and intentionally or unintentionally reinforce oppressive and unjust power dynamics. And I think a tangible example here is that if we're not explicitly embracing and embodying anti-racist values, we will reproduce the characteristics of white supremacy culture within our work. There's not really a values neutral or a principles neutral approach. And so we're very intentional in putting together what our co-design principles are as a center, and we want to work with you to help define that. And we want your help in defining out what it means for our center. I'm going to point again, KA has some really great resources out here on 6 mindsets for co-design. And I just wanted to briefly highlight these because I think they're wonderful. So KA highlights elevating the contributions and leadership of living and lived experience, elevating lived experience at every step, and aiming for the conditions that would allow for participation and partnership with those of lived experience. And that's not just participation in minimal input, but having a real role in leadership on work, projects, and decisions that are being made. Another mindset that's really important for co-design is practicing curiosity, softening our judgments, extending grace, and letting go of a little bit of certainty that we have. It's difficult to do, but really important as we come together as a community. Third mindset for co-design is being in the gray. I've also heard folks refer to this as embracing ambiguity. This is our willingness to be unclear and our willingness to not rush things and allow things to develop as they need to, and moving at what I've heard folks say is move at the speed of trust. This is difficult, and not every stage of the DDBT process will require you to be in the gray, but this is an important mindset to hold on to when it is needed. Fourthly, valuing many perspectives, so incorporating differing and opposing views. Folks, disagreement is not always bad. It can be really generative as we're working on things. Also really important is learning through doing. In the design world, you may hear this referred to as a bias towards action. So learning through doing is kind of baked into the DDBT process, particularly the design, build, iterative cycle there. And then lastly, we want to be offering generous hospitality to the folks that we're inviting in. KA is really has a beautiful note here about careful planning. It's actually splitting the word careful to be full of care, and being full of care for people's various physical, emotional, access, and cultural needs, and being careful not only for others, but also for your own needs as you're going about this work. So I think that's a good jumping off point and a conversation starter about co-design. I also want to put out that there are other perspectives for consideration when it comes to principles and values around design. I'll highlight just a few here. The design belonging principles, come from the Othering and Belonging Institute at the University of California, Berkeley. I think they're really wonderful and something you should check out and look into and see how they might influence your project. Second one I wanted to highlight here is the Design Justice Network. This is a really wonderful network of designers across the country, across the world, and they have a list of 10 principles, and they frame design justice as rethinking design processes where it centers people who are normally marginalized by design and uses collaborative, creative practices to address the deepest challenges that our communities face. And I certainly think suicide care fits within that vein. And then lastly, I wanted to reference something that's near and dear to me, this trauma responsive design framework. This is from an old mentor, a social worker and designer that I look up to immensely, and I'm lucky to call a friend, Rachel Dekas. She's mapped out here a call for trauma responsive design that takes social work values, design research methods, and trauma-informed care principles into a trauma-responsive design framework. More on that to come. I think that's going to be a continued conversation within our center. So that was a quick note on co-design. We've covered an introduction to what we mean by design, the DDBT framework outcomes and measures, and then co-design. So as we're wrapping this up, I want to reiterate the learning objectives. I hope that you now feel like you can summarize the 3 phases of the DDBT framework and the respective outcomes for each phase. I hope that you can align your research plan and you feel prepared to align that methods included with the DDBT approach via our intake process. And then lastly, I hope that you can recognize DDBT's connection to the preparation phase of the MOST framework. And if you're interested in learning more about DDBT beyond what we will be, including what we will offer as a center, but also beyond that, just some things to look forward to for right now at the time of recording. On April 24th, we're going to have a synchronous seminar on human-centered design as a method of, or as a way to achieve the preparation phase goals in the Multiphase Optimization Strategy framework. And then on June 26th, we have a synchronous seminar on human-centered design research for addressing health equity and touching on trauma-informed, trauma-responsive design. And then on campus, there's also the Design Use Build seminar series that's ongoing, and I encourage you to check that out. Google that and find out what those are. They bring in speakers about every week or every 2 weeks. Thank you so much for watching this recording, and if you have any questions, please reach out to SCRC's Methods Core. I'm just going to briefly show our references here, and that concludes this overview of the DDBT framework.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.